start. Hope more people will be joining in. My name is Goldberg Hanan. I hope everyone is hearing me well. Please let me know if not, through me or either through Riken. I'm a uro-oncologist from SUNY Upstate Medical University. I started working there a few months ago. I finished my fellowship in uro-oncology in Princess Margaret Cancer Center in Toronto. I did a 3-year clinical and research fellowship. And I'm very happy to start working that I started working at SUNY Upstate under Dr. Braslavsky, and I'm very happy to join you today and give you this talk about upper tract urothelial carcinoma and also a little bit about Lynch syndrome. So I think we'll get started. So this is the outline of our talk. Again, we'll try to cut down some things if it will be too long, but background, comparison of upper tract to bladder cancer, epidemiology, symptoms, diagnosis, evaluation, staging, and risk stratification. I'm going to talk about different kinds of treatment, different types of surgery, lymphadenectomy, variant histology, some recent work about chemotherapy, neoadjuvant and adjuvant chemotherapy, bladder recurrence, what is the role of radiotherapy. A little bit we'll touch about the treatment of metastatic disease, and then we'll end with Lynch syndrome and some take-home messages. Please, again, feel free to ask anything through Riken or through a chat or whatever works out for you, and I'll gladly try and answer to the best of my ability. So a little bit of background. This is a primary malignant tumor of the ureter and renal collecting system, the pelvis, the calyces, the infundibula. 90% of them are of urothelial origin. There's also other cancers like in bladder, squamous cell carcinoma, adenocarcinoma, small cell, but these are less common, of course. Benign tumors, which we will not touch in this talk, fibroepithelial polyp, inverted papillomas, fibromas, and von Brun's nets, just to mention a few. The risk factors are very similar to those of bladder cancer, smoking being the number one risk factor. Bladder cancer itself is a risk factor, as this is a pan-urothelial disease. CIS, multifocality, proximity to the ureteral orifice, these are all known risk factors for upper tract disease. Lynch syndrome, which we will touch and go a little bit deeper later on in the talk. Aristolochic acid, which we'll also discuss, something unique for upper tract disease. Arsenic, analgesics, occupational exposure to all kinds of chemicals, chronic inflammation and infection, and cyclophosphamide. So smoking, I'll just touch about some important risk factors. Smoking is the long recognized number one risk factor, accounting for anywhere between 25 to 60% of upper tract disease. As I previously mentioned, bladder cancer itself is a risk factor. Used to be classical data showed that this was a higher percentage, but more contemporary data showed that this is actually much lower than we thought, less than 1%. Aristolochic acid, as I mentioned before, is a special mutagen that is found in various plants that are especially used in the Eastern Asian herbal remedies. It also grows near the Danube River in Europe, and it can cause upper tract urothelial carcinoma. There's been many studies on this, and nephropathies, the Balkan nephropathy, and the Chinese and Taiwanese herbal nephropathy. Other risk factors, as I mentioned, analgesic overuse, exposure to phenacetin that is not used anymore, and cyclophosphamide. Lynch syndrome, which is also called hereditary non-polyposis colon cancer. Approximately 10 to 15% of patients with Lynch syndrome develop upper tract disease, and as I said before, we will go into this a little bit more in detail later on because I think it's quite interesting. So a little bit of a comparison to bladder cancer. This is just touching on this. There's a lot of work now going into this, especially genetic and molecular profiles, which are quite different between these two diseases. In the past, it was considered that these are the same disease, but we are finding out that they are quite different. So they do demonstrate a similar spectrum of genetic alterations, but the frequencies are different. In upper tract high-grade disease, there's increased alterations in FGFR3, which you might have heard of, HRAS, CDK, and 2B, P53 mutations, which is a very common mutation in cancer, exclusively seen in high-grade upper tract disease. Most of the upper tract urothelial carcinomas are closely related to the luminal papillary molecular subtypes, which are now a lot of work is being done into this, especially in bladder cancer. They have a much lower, upper tract disease has a lower tumor mutational burden compared to bladder cancer. And in about 17% of patients who develop upper tract, later on they develop bladder cancer as well. And this is an interesting finding. The history of previous bladder cancer is very different around the world in patients who have upper tract urothelial carcinoma. In Americans, it was found at approximately 40%, but in Chinese patients, for example, it was found to be 4%. So there's a lot yet that we need to learn about this disease and its correlation to bladder cancer. A little bit about the epidemiology. It's a rather rare disease. Only about 5 to 10% of all urothelial carcinomas. The annual incidence is about 2 to 100,000 people. Most patients present with invasive disease, about 65%. Again, this is very different if you compare it to bladder cancer, where only about 25% of patients present with muscle invasive disease. 7% only present with metastasis. The peak incidence are as elderly individuals above the age of 70 usually. It's twice as common in males compared to bladder cancer, which is 4 times as common in males. Generally, stage for stage, the outcomes are considered similar for renal, pelvis, and urothelial cancers, but the renal pelvis cancers are usually twice as common. And CIS is present in between 10 to 30% of cases. The symptoms are again, something that I'm sure you all know. Hematuria is the most common one. Gross macroscopic is usually a big sign. Flank pain, dysuria, symptoms of any kind of advanced cancer disease, and the common sites of metastasis: liver, lungs, bones, and regional lymph nodes. The diagnosis is usually made by first the patient presenting with hematuria. That's the most common, and then we are, doing a full hematuria workup. And on imaging, on contrast-enhanced imaging, we see filling defects, either on CT scans or MRI. Sometimes hydronephrosis as well. Occasionally, we can see positive cytology with negative cystoscopic bladder and urothelial evaluation. Filling defect on delayed images of contrast-enhanced studies is considered upper tract urothelial carcinoma until it is proven otherwise. That's an important point. And direct visualization is needed to rule out other etiologies like blood clots, radiolucent stones, sloughed papillae, or mucosal folds, which can also cause a filling defect on scans, on CT scans and MRI scans. The evaluation usually cystoscopy, retrograde pyelogram, and ureteroscopic evaluation with biopsy and selective washings. Selective washings on top of the biopsy can serve as an additional prognosticator. And if there's no solid tumor, a positive selective cytology a lot of the times can indicate CIS. Again, we're using imaging contrast enhanced with either a CT scan or an MRI, MRU, or CTU. The MRI is usually used in patients with iodine allergy or poor renal function. Chest imaging for staging and for evaluation of metastatic disease. And only if bone scan we do only if there's clinical suspicion. We can do lab study. We should do lab studies as well, which includes creatinine, liver function test, alkaline phosphatase, cytology, of course, and culture. Some people refer to renal scans, especially if you're deciding what kind of treatment to do, and we'll touch on this later on. Whether you need to remove the kidney, what's going to be the patient's status with his remaining kidney. So this is sometimes very important information to have before treating the patient. Staging, so this is a little bit of a problematic issue in upper tract disease, much harder than bladder cancer. Ureteroscopic biopsy and current cross-sectional images are quite limited because we have a problem discerning how invasive the disease really is. Biopsies, a lot of the times, do not have enough penetration, and we can get something that looks like a TA or a T1 when it's actually a much more invasive disease, and that's been shown to be a problem in upper tract disease. There's some data showing that up to 30% of the biopsies done in upper tract disease are not accurate, are actually understaged. Imaging as well is problematic, it does not give us enough resolution. And many tumors are actually staged TX because we're not entirely sure how deep the tumor goes. This is the TNM classification, again, very similar to the one of bladder cancer. TA, non-invasive papillary carcinoma, TIS, carcinoma in situ. T1 is subepithelial connective tissue. T2 invades the muscular layer, and T3 goes into the fat, whether it's in the renal pelvis or the ureter, and T4 goes out of the kidney, basically out of the organ already. This is the risk classification that I think is quite good. That is what is recommended and used by the EAU guidelines, the European Association of Urology guidelines. And that helps you in deciding what kind of treatment you're going to do. So for low-risk disease, you have to have all of these criteria to define a disease as low-grade. It has to be unifocal. The tumor has to be smaller than 2 centimeters. Low-grade cytology, low-grade biopsy, and no invasive aspect on CT urography. And for high-risk disease, it's enough to have only one of these criteria to define it as a high-risk tumor, and that has implications for the treatment. So hydronephrosis, a tumor larger than 2 centimeters, high-grade cytology, high-grade biopsy, multifocal disease, previous radical cystectomy, and variant histology. So let's go a little bit into the treatment. So we'll start with when do we think about doing an organ-sparing treatment? And we'll talk about the standard, classical, gold standard treatment of radical nephroureterectomy, but when do we need to consider organ-sparing treatment? So if we have compromised renal function or a solitary kidney, of course, that's an indication. Generally, it's better to limit this to low-risk, low-grade diseases. It can combine endoscopic treatment with ureteroscopic laser ablation or percutaneous resection, with or without adjuvant intraluminal installations. Segmental ureterectomy is also another option with urinary reconstruction, but we have to follow these patients very closely as recurrence rates can be high. This includes urinalysis, cytology, ureteroscopy, and of course imaging. So with endoscopic treatment, patients with low-risk tumors that are accessible via endoscopy may be managed with this endoscopic treatment using laser. There's actually a systematic review published in 2016 from European Urology that actually looked at this and compared for low-grade disease, only for low-grade disease, the treatment with radical nephro-U and nephron-sparing surgery or endoscopic treatment, and it showed that they had all equivalent overall survival, but the studies, there's a limitation. Most of the studies are from institutional case series with a huge selection bias, so we have to take this with a grain of salt. Intraluminal treatment. So this is quite challenging. It's not like in bladder cancer where we can have the patient hold it, just close the catheter or tell the patient to hold it for 2 hours and then he can urinate it. And the kidney and the ureter, it's quite problematic because of the drainage and the limited indwelling time. So there are 3 primary methods to deliver intraluminal agents to the upper tract, either through a nephrostomy tube or through a ureteral catheter or through passive reflux with an indwelling double J stent. So all these strategies are limited due to obvious reasons and due to the fact that there's also pilovenous backflow that you need to remember in the kidney. This may result in higher systemic absorption of these agents, not like in the bladder. And then we have higher rates of side effects. Recently, mitogel, I don't know if you've heard of this, but this has been introduced. This is mitomycin C in reverse thermosensitive hydrogel polymer, which is called mitogel, which has just recently been FDA approved as well. The Olympus trial evaluated patients with one or more papillary lesions less than 1.5 centimeters with low-grade histology. And the preliminary results that were first presented at the AUA last year demonstrated almost a 60% complete response rate after induction therapy. And most common adverse events were urinary tract infections, ureteral narrowing, and stricture. Before going to BCG, so it's important to know this is how it looks like. The amazing thing about this is that it comes in a liquid shape, but when you put it into the patient's kidney, it actually forms to a solid shape, allowing the urine still to pass through it, so it's not obstructing the kidney, and it stays there for a few hours until it again converts to a liquid state and then just clears out of the kidney. So this is quite revolutionary, and it's interesting to see how will this be used in the future. Let's move on to segmental uretrectomy. So this is removal of the diseased portion of the ureter and reanastomosis. Again, this should be done, at least with the data that we have so far, mainly for small unifocal ureteral tumors that are not amenable to ureteroscopic treatment. For distal ureteral tumors, we can do a distal uretrectomy and just a reimplantation. For proximal ureteral tumors, we do segmental uretrectomy and primary ureterotomy or ureterocalicostomy. This can be done either an open laparoscopic or robotic approach. Well, we basically ligate the ureter and a wide cuff of the bladder, and the complications include ureteral stricture and urine leak, which are usually managed conservatively. Moving on to the gold standard treatment, this is the radical nephrouretrectomy. So the indications are usually when the nephron-sparing surgery options are not feasible or oncologically possible. Again, this can be done with either open, laparoscopic, or robotic approach. It requires complete removal of the entire kidney with Gerota's fascia, with the ureter and in a bladder cuff. The ureter is traditionally clipped early to prevent a disrupted tumor from seeding, and usually we try to leave the adrenal gland and not take it out. There are several techniques that have been described for the management of distal ureter and bladder cuff. There's book chapters that have been written about this. And basically, there's the extravesical approach where you just follow the ureter all the way down to the bladder and try to take as much as you can, and hopefully take a large enough piece of the bladder with you. Transvesical approach where you do a cystotomy, basically open the bladder and resect the ureter from both sides, both from inside the bladder and from outside the bladder. And there's also an endoscopic pluck approaches. There's many modifications and many kinds of many different versions of this, but basically you start the case with a cystoscopy and basically aggressively resect the ureteral orifice and basically do what you're not supposed to do in a TURBT. You actually perforate and then you just remove the ureter from outside the bladder. So a large international retrospective study compared all these approaches and basically found no difference in terms of overall survival or cancer-specific survival or recurrence-free survival, but the endoscopic approach was associated with a higher intravesical recurrence rate. But again, it's interesting to hear what different people do. I usually do the transvesical approach. I do a small cystotomy in the bladder. That's how I was taught, and I basically remove the ureter from inside the bladder and from the outside, and I think that's the safest way, at least according to what I believe in, but I'm not sure that's the right thing. So what about the different modalities? As I mentioned previously, it can be done in all kinds of modalities: open, robotic, and laparoscopic. So there's actually a paper published last year in the World Journal of Urology comparing robotic versus other modalities of radical nephrouretrectomies. They looked at a very large number of patients, 80 studies, more than 87,000 patients, robotic. They compared it to open, to laparoscopic, and hand-assisted laparoscopic. And these are the findings that they showed. I'm just summarizing them. You can read the paper if you're interested. Robotic RNU had, as can be expected, the lowest estimated blood loss, lowest rate of intraoperative complications, and the shortest length of hospital stay. And the open had the highest rate of blood loss and the shortest operating times. And interesting, it had the lowest 5-year cancer-specific survival rates. Where the hand-assisted laparoscopic has the lowest risk of positive surgical margins, recurrence rate, metastasis, and cancer-related death. Let's move on to lymphadenectomy, also an important topic, whether we should do this in upper tract disease, and if we should do this, what kind of templates we should use. This is a review that was published this year. So regional lymphadenectomy should be considered prognostic and possibly for therapeutic purposes as well. The current thought is that it most likely will benefit advanced disease T3 and high-grade patients, whether they're clinical N0 or N+. It should follow a strict anatomical template, and we'll talk about that too. And usually it is considered safe and does not increase significantly the surgical complications. Again, it can be done in various surgical modalities. That does not seem to impact the results. And according to most studies, a minimum of 8 lymph nodes should be removed at least. And a term called lymph node density, which is the mean ratio of positive nodes to the total nodes removed, is actually a more precise index to predict outcome than just lymph node count. When looking at there's actually a randomized trial that is actually assessing this now, that is ongoing and recruiting patients. And when you look at the templates, it's actually very similar to testis cancer. And you can see this is for primary tumor of the right pelvis in the green. This is for the left side in purple. This is for the primary upper two-thirds of the ureter on the right side. And this is on the left, and this is what you do if it's in the distal ureter. So you try to pretty much take the whole pelvic and lymph nodes from templates that we know from other cancers like bladder and others as well. Variant histology. There's been a lot of work into this in bladder cancer, but this also exists in upper tract disease. This was published this year as well, a very large paper. So what they found is 1 out of every 10 patients with upper tract urothelial carcinoma had variant histology. It was associated, as can be expected, and as you can see in bladder cancer as well, with adverse pathological features. But when they adjusted for confounders, only the micropapillary and sarcomatoid variants were associated with poorer outcomes, as you can see in this graph. So this is a recurrence, the cumulative incidence of recurrence, and the red here is the micropapillary, which is higher than everyone. And when they did the multivariable analysis, compared to urothelial, so only micropapillary was statistically significant and showed to increase the rate of recurrence. This is cancer-specific mortality, and you can see the orange is the sarcomatoid, which is way up higher than all the rest. And again, in the multivariate analysis, comparing with the reference of urothelia, the sarcomatoid was very high risk for cancer-specific survival. This is a very aggressive and bad disease. How do we follow these patients after treatment? That's also a large issue that's debated. This is from the EAU guidelines. It just summarizes it quite well. That's why I chose to put it here. So this is after radical nephrectomy. They divided to low-risk tumor or high-risk tumors. If you remember, I showed you how to divide low-risk and high-risk. So they're using this classification. So low risk is anything less than unifocal disease, less than 2 centimeters, low-grade cytology, low-grade biopsy. And they recommend doing cystoscopy at 3 months, and if negative, subsequent cystoscopy 9 months later, and then yearly for 5 years. If it's high risk, cystoscopy and cytology at 3 months, and if negative, you repeat it every 3 months for a period of 2 years, and then every 6 months for 5 years, and then yearly. For how long? Very good question. Nobody knows whether it's for life, or 10 years, or 15 years. I've heard many opinions on this, and I don't think we really know yet. This is for kidney sparing management. So again, divided to low risk and high risk. So for low risk, you do cystoscopy and CT scans, because you're always worried about recurrence. Every 3 to 6 months, and then yearly for 5 years. You also do your ureteroscopy in 3 months. And for high-risk tumors, again, cystoscopy, cytology, CT scan, chest CT scans, and then yearly. And then you also do ureteroscopy and urine cytology at 3 and 6 months. Let's move on to chemotherapy. So this is, again, an evolving topic with many studies recently, and we'll talk about the adjuvant chemotherapy with the POUT study, which is a very important study. But let's start with neoadjuvant chemotherapy. So again, this is the rationale is that we're borrowing from bladder cancer literature, where neoadjuvant chemotherapy provides a survival benefit. So it is assumed that the same benefit is provided for upper tract disease as well. Also, specifically in upper tract disease, most patients are renally impaired after surgery, and a significant proportion loses their eligibility to get cisplatin therapy because they've lost one kidney. So that's another reason why to choose neoadjuvant chemotherapy. There's lots of the regular regimens are used here: gemcitabine plus cisplatin or MVAC. The first prospective study of neoadjuvant dense MVAC prior to radical NEFRU in patients with high-grade urothelial carcinoma demonstrated pathological response rate of 14% and a 62% rate of less than T2 disease. And several other trials are currently evaluating the role of neoadjuvant chemotherapy prospectively. This is one of them, but there are many others. Also now with the introduction of immunotherapy with checkpoint inhibitors that we're trying to give them as early as possible in various diseases. And this is also investigated in upper tract disease, whether we can give this as neoadjuvant therapy before surgery. Let's move on to adjuvant chemotherapy. So patients with invasive upper tract disease follow definitive local therapy at high risk for metastatic disease. That's the rationale. There's no high-level data supporting neoadjuvant chemotherapy so far, so it was assumed that it's better to give adjuvant. And we have the POUT trial, as I mentioned earlier, which is a large randomized phase 3 trial that was published in Lancet and demonstrated that adjuvant chemotherapy, consisting of 4 cycles of gemcitabine and cisplatin, resulted in improved progression-free survival and cancer-specific survival when you compare it with surveillance. This is the trial. I recommend reading it. It's a very well-done trial. It was the first randomized controlled trial powered to demonstrate a difference in disease-free survival in patients following definitive surgical therapy. And they took all patients, PT2 and upwards. They stopped early because they reached their endpoint quite early. And they show the disease-free survival events has a ratio of 0.47 in favor of chemotherapy. And they also investigated other endpoints that were shown to be favoring adjuvant chemotherapy. This is the trial design, as I mentioned before. That's the inclusion criteria. As I said, it's T2 and above, all lymph node status disease. These are the exclusion criteria. And basically, if you look at the results, I hope you can see this. So this is the disease-free survival. So the red is chemotherapy and the blue is surveillance. So you can clearly see there's a huge advantage with a hazard ratio of 0.45 for disease-free survival, and also for metastatic free survival, again with a hazard ratio of 0.48. Overall survival, the data was not mature enough, but it does seem to have an overall survival advantage as well, which we'll probably see. We'll probably see it in the next publication with follow-up data. This is a systematic review and meta-analysis of both neoadjuvant and adjuvant chemotherapy that was published beginning of this year. They just showed, in general, they looked at many studies, over 20 studies, over 15,000 patients. And for neoadjuvant chemotherapy, they showed benefits, pathological downstaging, complete response, very high risk ratios, overall survival benefit, cancer-specific survival benefit, and for adjuvant chemotherapy, they showed this as well. Improved metastasis-free survival, cancer-specific survival, and overall survival only in locally advanced upper tract disease. So again, the data shows, at least from retrospective studies, that there's probably an advantage to both. But again, we only have level 1 evidence for adjuvant chemotherapy, but there are ongoing prospective trials that are now assessing and looking into the neoadjuvant, and we will wait to see what these trials show. Moving on to bladder cancer recurrence. So this occurs approximately 20 to 45% of cases, and about 2 to 6% of patients have contralateral upper tract urothelial carcinoma. There's been 2 randomized prospective studies that have shown a significant reduction in the recurrence of bladder cancer after a radical nephroureterectomy when you use intravesical therapy right after surgery for the upper tract disease. Basically, there's 2 studies. One of them was published in 2011 in European Urology, looking at mitomycin C, and the other one was published in JCO in 2013, looking at another chemotherapy, which is called pirarubicin. And again, the results are quite significant. The absolute reduction for mitomycin was 11%. The relative reduction in risk was 40%, and the number needed to treat to prevent 1 bladder recurrence was 9 patients, which is quite low. Pirarubicin, the hazard ratio was 0.26, very low. And also a Cochrane review suggests the benefit in recurrence rates with a hazard ratio of 0.51 with a single installation of chemotherapy postoperatively. Interestingly enough, this is not common. Not a lot of big centers do this. It hasn't caught on. I don't know exactly why. We didn't do this always. Sometimes we did, but not on a regular basis. But probably we should do this much more. What about radiotherapy? This was published a review article in Urologic Oncology about the role of radiotherapy after surgery for upper tract disease. So again, basically hasn't been defined yet. There are some single center studies that suggest the benefit for this in conjunction with systemic chemotherapy in the setting of locally advanced and metastatic disease as well. But there's no clear evidence of it as of yet, so this is currently not recommended in any of the guidelines that we follow. What about radical nephroureterectomy and metastatic disease? So this is a study that was published in this year looking at radical nephro-U in patients with metastatic upper tract disease. Very similar to what now the data that is coming for prostate cancer and treatment in oligometastatic disease. So several observational studies have explored this in metastatic disease. It may be associated with cancer-specific and overall survival benefit in select patients, especially those fit enough to receive cisplatin-based chemotherapy. Usually it's better to use it in patients with only one metastatic site. Like it's not oligometastatic, but it's only one. To date, there's no specific study supporting the role of metastatectomy in these patients. But some evidence suggests that resections of metastatic lesions could be safe and oncologically benefit in select patients with a life expectancy of more than 6 months. But again, this is still experimental, and we don't have hardcore evidence about this. A little bit about the treatment in general of metastatic disease. We won't go too much into this. So the usual first-line treatment is cytotoxic chemotherapy, and the response rate are about 20 to 60%. Patients who are cisplatin ineligible, which is the recommended chemotherapy, may be treated with gemcitabine or carboplatin, but this is not recommended by European urology guidelines. Checkpoint inhibitors are now also an option. They were first approved in 2016, and we have a total of 5 checkpoint inhibitors that we can use in urothelial carcinoma. And the indications, as I previously mentioned, are advancing into earlier stages of the disease. And patients can get first-line immune checkpoint inhibitors if they are cisplatin eligible or if the tumor stains positive for PD-L1. The common side effects of these checkpoint inhibitors include colitis, endocrinopathies, nephritis, liver toxicity, skin rash, pneumonitis, but many others as well. This is according to, again, it's a nice table summarizing the recommended treatments in metastatic disease according to the European guidelines. So first-line treatment for cisplatin-eligible patients is to use cisplatin chemotherapy. If patients are unfit for cisplatin, so checkpoint inhibitors are now recommended, pembro and atezolizumab. Alpha carboplatin combination chemotherapy if PD-L1 is negative. Second-line treatment is again checkpoint inhibitors, and we will see this being incorporated in the guidelines more and more. This is according to the NCCN guidelines, which is again very similar, and we talked about all of this. It pretty much summarizes the various treatments for low-grade disease. You can choose either radical nephro-U or endoscopic resection. For high-grade disease, usually radical nephro-U is what's recommended, the gold standard. And for metastatic disease, you give systemic therapy. This is of the ureter. So before it was of the renal pelvis, as you can see here, and now it's for the ureter. So again, various options for low-grade disease, endoscopic or segmental uretrectomy or radical nephro-U, and pretty much it summarizes what we discussed up until now. This is the adjuvant treatment. So for PT0, PT1, most likely you don't need anything else. For PT2 and above, since we have the PALT trial, so now it's being, this is new, consider adjuvant chemotherapy. I have a feeling that in future versions of the guidelines, because of the PALT trial, this will be more mandated to use chemotherapy because of the positive results, but time will tell. This is again a summary from the EU guidelines, which is just a nice algorithm showing the various treatments that we discussed and the various options. I think we'll move on to Lynch syndrome, and then we'll have time for questions about everything. This is the last section of the talk, and we'll try to finish it a little bit earlier if possible. So Lynch syndrome, which is hereditary non-polyposis colorectal cancer, was originally reported approximately a century ago. And then it was called cancer family syndrome. And in 1984, it was named Lynch syndrome and recognized as one of the first hereditary cancer syndromes. The incidence is about 1 in every 250 to 1,000 patients. Most common cancers associated with this is colorectal and endometrial cancers, and upper tract is the third most common cancer. So about 1 to 4% of all colorectal cancer cases are associated with Lynch syndrome. There's many other associated cancers, and we're finding out as time goes on that there's more cancers that can be associated with this: small bowel, hepatobiliary system, ovary, glioblastomas, pancreas, prostate, and others as well. So what is Lynch syndrome? It's a genetically acquired condition of defective DNA mismatch repair system. The mismatch repair system is a post-replicative proofreading and editing mechanism, which basically maintains the integrity of our genome. And these can be mutated, and then we can get cancers. The cancer is developed because of an autosomal dominant heterozygous germline mutation in one of the 4 most common MMR genes, the MLH1, MSH2, MSH6, and PMS2. There's also another gene called the EpCAM, which can also be affected. And the cumulative cancer risk of upper tract is specifically higher in the MSH2 and MLH1, and with the gene mutation carries about 1 to 7%. These cancers commonly manifest what's called microsatellite instability. Microsatellites are short recursive DNA nucleotide sequences that are found throughout our entire genome. We don't really know exactly what they do yet. There's lots of theories, but nobody knows exactly. And in instability of these macrosatellites, there's changes in the length of the recursive regions, causing single base point mutations. And you can actually test this using polymerase chain reactions or immunohistochemistry and find these mutations. Interestingly, the instability, microsatellite instability, is not 100% specific for Lynch syndrome. because you can also find this in sporadic colorectal cancers, where the prevalence is about 15%, while in Lynch it's over 90%. But these can occur in sporadic cases which are not related to Lynch syndrome, and that's why we're not entirely sure what this is, but this is a very common finding in Lynch syndrome, over 90%. And that's why it is used for diagnosis. So how do we diagnose Lynch syndrome? So initially, we use the clinical Amsterdam criteria of the SETA guidelines, which I will show you as well, to identify candidates for Lynch syndrome testing. In the beginning, there was Amsterdam 1 criteria, and later on the Amsterdam 2, which were revised and upgraded. The Amsterdam 2 criteria has a specificity of 98% with a very low sensitivity of 22%. And the SETA guidelines has a sensitivity of 82 and specificity of 77%. But again, these criteria are far from perfect, and you can see they can miss up almost 30% of patients. And today, universal screening for Lynch syndrome using the microsatellite instability and or immunohistochemistry for the mismatch repair genes has been implemented gradually, but it's mainly in colorectal and endometrial cancer cases, which is where the Lynch syndrome is more common. But there are places that are starting to do this for patients with upper tract disease as well. These are the actual guidelines. I'll go straight to the Amsterdam 2 criteria, which are the newest ones and more updated ones from 1999. So 3 or more family members, one of whom is a first-degree relative of the other 2, who have hereditary non-polyposis colorectal cancer-related cancers, 2 successive affected generations, 1 or more colon cancer diagnosed before age 50. The BETSETA, which is the more recent one and more detailed, again, shows colorectal cancer diagnosed at any age younger than 50, presence of synchronous or metaconous colorectal cancer, or another Lynch syndrome-associated tumor, or colorectal cancer with high microsatellite instability, pathologic associated features, patients with diagnosed in at least one first-degree relative younger than 50 years old, and patient with colorectal cancer and colorectal cancer or Lynch syndrome-associated tumor at any age in 2 first-degree or second-degree relatives. Again, you don't need to remember this. It's a little bit complicated even to read, but these are the criteria, the clinical criteria that we use to send patients for testing, specifically for microsatellite instability. When you diagnose these patients early, it enables you to reduce cancer risk through intensive screening, follow-up, and prophylactic surgery as well. The NCCN guidelines pretty much recommend that you should test for Lynch syndrome in patients who are younger than 50, who have colorectal and endometrial cancer, who meet the Amsterdam 2 criteria of the SETA guidelines, and for patients with a known Lynch syndrome family history. When you look at the EAU guidelines for urology, so they also have a recommendations for upper tract patients. So upper tract urothelial carcinoma patients should undergo germline DNA sequencing testing for Lynch syndrome if they are younger than 60. As you remember, this upper tract disease is usually prevalent in age 70 and above. So if you have a patient who is younger than 60, has a personal history of Lynch syndrome, or has a first-degree relative younger than 50 with a Lynch syndrome-associated cancer, or 2 first-degree relatives with any Lynch syndrome-associated cancer, he should be tested for Lynch syndrome. So this is an important recommendation by the EU guidance, specifically for upper tract urothelial carcinoma patients, when you should test them for upper tract disease. And this is an important step that they made about this. As I said before, the MSH2 mutations increase the risk of several colonic tumors, but most notably upper tract disease. These are found in 77% of urothelial tumors and 74% of renal pelvic tumors. There are other urological malignancies that can be described as part of Lynch syndrome. There's data showing that bladder cancer can have an association, prostate, testis, and even RCC. Using the Amsterdam with the SETA criteria, patients have an increased risk of Lynch syndrome patients have an increased risk of up to 17 times and 22 times for renal pelvis and urothelial upper tract disease, respectively. Lynch syndrome associated upper tract disease The lifetime individual risk can be as high as almost 28%. And this study, it's a very nice study that was published in MD Anderson in Journal of Urology, where they did universal point-of-care testing using the Amsterdam 2 and immunohistochemistry criteria in consecutive upper tract patients, upper tract urothelial carcinoma patients. They found that almost 14% of patients harbored potential Lynch syndrome, according to the clinical criteria, and 5.2% were confirmed to harbor disease. So this is an important finding that more than 5% of our upper tract patients have Lynch syndrome that they don't know about, and it's important for us to diagnose that. So as I said before, this is largely underestimated with lacking awareness among most urologists. So a little bit of a summary about upper tract urothelial carcinoma associated with Lynch compared to the sporadic regular upper tract. So it's more common, the Lynch syndrome one is more common among women. It's diagnosed in a younger age. There's more urothelial tumors, more bilateral tumors, and may exhibit a better response to adjuvant chemotherapy after radical nephrectomy. The tumor risk stratification is basically the same as for a standard tumor, and the follow-up protocol of Lynch syndrome patients who undergo radical nephrectomy is similar to non-Lynch syndrome patients: cystoscopy, cytology, as we mentioned before, and CT urography. Basically, patients who have Lynch syndrome, who we know will come to our clinic with a known diagnosis of Lynch syndrome but have not had any cancer diagnosis, this is the recommended protocol for surveillance in these patients. So I marked specifically upper tract and bladder. So these patients should start being surveyed, even if they have nothing urological. They should start being surveyed at the age of 30, 35 for both upper tract, especially upper tract, but for bladder cancer as well. So they should have annual urinalysis, urine cytology, renal ultrasound, or computed CT scans. It's important from the age of 30 to 35. So if a patient comes to you and is known to have Lynch syndrome, even if he has no diagnosis of any kind of cancer, this is the surveillance protocol he should start at a very young age. Some take-home messages, and then we'll have time for questions if there are any. So in upper tract disease, it's important to tailor the treatment for each patient, consider renal function, comorbidities, disease location, tumor stage and grade, number of tumors, multifocality. The gold standard treatment, it's important to remember, still radical nephrectomy. However, for select patients, segmental resection may be performed. Endoscopic management is also reasonable in low-grade disease, low-stage disease, as long as they adhere to a very strict follow-up protocol. So that's compliance of the patient is very important when choosing this kind of treatment. If you know that the patient is not going to be compliant with a strict follow-up protocol, he cannot be offered such a treatment. The benefit of adjuvant radiotherapy is still debated. Currently, there's no role for this. Adjuvant chemotherapy should be considered for locally advanced disease, PT2 and above. Immunotherapy as an emerging therapy for advanced metastatic disease. And regarding Lynch syndrome, we must be aware of this and increase our awareness to identify risk patients for Lynch syndrome. It's an important thing that we should do. And I do this with every patient, is asking about personal and familial cancer history. And pretty much that's the Amsterdam criteria or the Bethesda criteria. If you see that the patient has significant cancer history in himself or his family, that should raise a red flag. Once Lynch syndrome is established, early detection, referral for appropriate testing, and screening for other associated cancers are very important. Thank you very much, and I'll be happy to answer any questions.